Good afternoon, everybody, and welcome to the Seeing is Believing Southeast Asia and Western Pacific Regions webinar. Thank you all for attending today. I know how busy everyone is, and I really appreciate you taking the time to join us. Now, if you're an attendee, you can't actually see the other attendees, but we actually have 25 people who are attending this afternoon, or this morning for me in the UK. So we've got 25 of us on, which is absolutely fantastic, and more than last time actually, so that's really positive. And we've got people from Vietnam, India, Nepal, Indonesia, Bangladesh, I can see, Cambodia, China. So we've got a really wide participation from SiB partners. So it was absolutely fantastic. So thank you all for joining us today. Also, a big thank you to our webinar presenters, Mr. Pham Quoc An, the Country Manager of the Fred Hollows Foundation and from Vietnam, and Arundhati Bhattacharya, the Programme Officer from Sightsavers India, for their willingness to share learning from their Seeing is Believing projects on the theme of sustainability. So the agenda for today's webinar will be, firstly, a brief introduction from me on housekeeping and sustainability in Seeing is Believing. Secondly, presentations from our two speakers, and each presentation will be approximately 15 minutes. And thirdly, I will chair a question and answer session after the two presentations. So the webinar will take 1 hour in total. Firstly, some housekeeping points. I have currently shared my screen. I'm just going to do that quickly now. So if I click on clean screen. So in the next few moments, you should have a sign coming up saying waiting for next screen. And in the next few moments, you should see the sustainability slide, which is actually the first slide of our first presentation. So you should be able to view my computer screen through the GoToWebinar window. And each speaker will share their, I'll share the presentations during their, I'll share my screen during their presentation, so I'll be clicking through the presentations. And I have forwarded you the PowerPoint presentations in advance. So everyone's microphones are muted apart from the speakers, as this just ensures a better quality sound on the webinar. So as I say, we'll be doing a question and answer session at the end. So if you have any questions for the presenters, please type them in the chat box, and the chat box should be, there should be a panel on the right hand side of your screen, and there should be something saying chat, and if you click on that, then you can type messages in there, and then you can send messages to me. And actually I've already received our first question even before the webinar from Roshan from Cambodia, so thank you. We've already got our first question under our belt. So if you do have questions during the presentations, please send them across to me, because yesterday we had so many questions that the people that left it too late didn't get to ask their questions. So please do send your questions across. My colleague Saloni Nagpal is supporting us today with technical issues. So if you have any technical difficulties, for example with sound, you can send us a message in the chat box, and thank you Saloni for your support today. So from our experience, it's a good idea to close down any other web applications, for example Google, Outlook or Skype, to get a better quality of the call. And if you use headphones, it's a good idea to use those too. It just makes the sound come through a bit clearer. And also, I'm recording this webinar, and it will be uploaded onto the IPB website, and I'll send around the link in a few days. So even if you do miss bits, we are recording it, so you'll be able to catch it all. And then finally, at the end of this webinar, I'll be sending you a survey for your feedback. So the theme for this Seeing is Believing webinar is sustainability. So what do we at Seeing is Believing mean by sustainability? As you know, Seeing is Believing is Standard Chartered Bank's global initiative to tackle avoidable blindness and visual impairment in collaboration with the IAPB, and other NGOs and eye care organisations. The overall mission of Seeing is Believing is to create and strengthen sustainable eye care services in lower to middle income countries. Many Seeing is Believing projects have successfully impacted the following areas. Firstly, increase the accessibility and improve the quality of eye health service provision. Secondly, built capacity of eye health facilities through the provision of infrastructure and human resource training. And thirdly, improve the knowledge, attitude and practices of communities regarding eye health through education. But it's important that the changes made by Seeing is Believing interventions are sustained post-project. So the presentations today will explain some of the strategies Seeing is Believing projects have implemented or are still currently implementing to ensure sustainability of eye health programs. So firstly, let me introduce Mr. Pham Quoc An, the country manager for the Fred Hollows Foundation Vietnam, and he's going to do his presentation. So An, over to you.
Attendees, greetings on attendees from the Southeast Asia. I am very glad to be here today to share with you some lessons learned about sustainability of our programs that we have been implemented in Vietnam. Some background information for you. The Fred Hollows Foundation started its work in Vietnam in 1992, and it is almost 25 years now, and we receive a lot of Seeing is Believing projects funded for blindness prevention and eye care. And what I would like to share with you today is one of our model, that is the comprehensive eye care development projects. These projects started in 2013 and completed last year, 2016. Next, please. The title of the projects is Vietnam Comprehensive Eye Care Development Projects, and duration, it is 4 years, and locations, that is the 2 provinces in Mekong Delta, that is Vĩnh Long and Tiền Giang, and 2 others mountainous area provinces in Đắk Nông and Lâm Đồng provinces, and with the 1 million USD funded from the Seeing is Believing, and FAZ contributed 20% of the project funds, and the donors, that is the Seeing is Believing program. Next, please. Our strategies for the sustainability, because we started with our programs at the very beginning. This team will discuss among most of projects meeting with the partner, and we focus on the integrating of projects into the public health system. And in fact, in Vietnam, we have the public health, a very good public health system, and this is like a skeleton and the foundation for us to support. The second, that is establish the necessary physical facility to adequate screen, treat, and refer patients. And the third section, that is increase the number and building the capacity of public healthcare personnel so that they can provide good eye services. Another section that we would like to focus in the our strategy, that is increase the volume and quality of cataract surgery. It is also to reduce the backlogs and increase the cataract surgical rate per million annually. And the last part, that is strengthen the patient referral network for the patients to access to eye care service. Before our programs, they have a health network from the provincial level down to district, commune, and hamlet level. But the connections, the referral system amongst these levels are very weak, and we try to strengthen this referral network so that they can refer the patient from the lower level up to the high level for treatment. Our achievements sustainable during the after projects are illustrated as the following. Next, please. Firstly, that is integrate the project into public health system. As I have just mentioned to you that the public health system is Vietnam is run by the government, and it is the network is available. So our interventions, our project interventions focus on the strengthening of the district government hospital level, and because it is the primary level where the closer to the people, and where the people can access to have some simple and basic eye care services. And we involve a range of stakeholders in the health system into project implementations. For example, we have a hospital, we have the district health center, and we also have the other sectors like education and communication center to participate into the project implementation, so that they have connections amongst these stakeholders. And the people committees, that is the local authorities, are also involved in the project implementation because they allocate the budget for the health sectors. And we also recommended the provincial Department of Health to set annual target on eye care, like a blindness prevention indicator, to the lower level, so that this lower level set target for their staff and their divisions, so that they can contribute to achievement of the provincial target of blindness prevention. Next, please. The second component, that is, we established the necessary physical facilities. With the project's fund, we supported to build up to operating theaters and that meet national standard. And these operating theaters are equipped with the essential equipment that they can register with health insurance. And by registering with the health insurance, later they can use the health insurance cost to pay for the cataract surgery after the project leave. One pediatric eye examination room was renovated and in Tiền Giang province, and it is also create a good condition for the children to access to eye treatment, rather than they have to go to Ho Chi Minh City. It is about 150 kilometers away from the provinces. And as I mentioned before, District Eye Unit is the primary eye care service provider. So we also support with 10 district eye units renovated and equip them with, so that it create availabilities of the primary eye care services. Next, please. Together with the facilities and equipments, we also have interventions in capacity building for the public healthcare personnel. Before the project camps, some districts did not have any basic eye doctor or eye care staff. But during the project implementation, or by the end of the projects, the number of the basic eye doctor or ophthalmic nurse or refractionist of the district general hospital is increased in both in quantity and qualities. Under this project, a large number of eye care staff trained during the projects, and the district health staff were sent to training good and Quality Training Center in Hanoi, at the Vietnam Institute of Ophthalmology, or in Ho Chi Minh Eye Hospital, where the eye sectors was training. And with the capacity buildings for the eye care personnel, they can provide services, eye services to the local people, and they can get some incomes from these services. And some project management board allocate 30% of their interest for the internal development, including staff training after the project ends. Next, please. After having the strategies with the provincial Department of Health, with their supports and their agreements, involvements, and then facilities were improved, and eye care staff capacity and quantities was improved. Then the projects focus on increase the volume of and quality of cataract surgery. And during the project implementations, more than 1 million people access to eye screening, and more than 10,000 people would receive treatments for eye disease. The projects also apply cataract surgery surveillance system. It is a modifications of the CSOM, that is cataract surgery outcome monitoring, to monitor the cataract surgery outcome. And by doing this, the quality of cataract surgery was improved. And according to the system, inform us that 85% of the cataract surgery supported by the Fred Hollow Foundation in Vietnam was over 85% good vision VA's outcome, while the national VA's good VA's outcome only 60% as current draft reports. And with the projects support, more than 57,000 local people and more than 68,000 students improved their awareness about eye health through community eye care education section and the school talks. And we have a different diversifications of the forms of education, eye educations, like a school talks, group talks in communities, and also the communities talks with the eye messages, combined with the eye screening for the group of people over 50 years old. And the last components, the projects focus on that strengthening on the patient referral network. The community-based health staff, like common health eye health staff and Hamlet health volunteers, was provided with primary eye care trainings, and then they will participate in the project like first eye care staff, who can provide the eye message to the local people, and they can identify and refer the potential cataract or other kinds of patients to the higher level. And we engage with various mass organizations like elderly people association or women union or youth unions, and through these channels we channels the eye disease prevention message to the target groups. And through this network, it has facilitated thousands of adults and students access to eye care each year in the project's areas. Next, please. Next, please. And the project's approach also involve the local government into the project's implementation, as I mentioned before. But not just only involvement, but we also require them to make some funding contributions. And with our support, the project's province already developed the 5-year provincial blindness prevention plan, and it was approved by the people committees, and the people committees, I mean the local authority, agreed to commit some funds for the blindness prevention activities. Mutual agreement between Provincial Department of Health and Department of Education was signed by these two departments, and they agreed that after the project leaves, they will continue with the eye screening for the school students by using the health insurance funds from the provinces. And the hospitals and the partners who receive our support also commit that after the project ends, they will allocate budget for the maintenance, the equipment that provided by the projects under the government's guidance. By applying the comprehensive eye care model, we can ensure the abilities of quality eye care service at community level. This model is comprehensive. It touches on level of eye care network, from the provincial down to the grassroots level, that is hamlet level. It addresses on aspect of eye health, human resource, disease control, facility development, as well as advocacy and partnership with the local partners. It not only benefits the professional eye care system, but reaches the whole communities. And it brings eye care to the people who cannot access eye care services in the remote area by the outreach campaigns. And after the evaluations of these projects in 2016, it will conclude that the project provinces can now manage independently their blindness prevention mission and eye care services in their provinces. That is what I would like to share with you. Now it's time for your questions. Thank you very much for listening.
Thank you, Anne. That was a really interesting presentation with lots of fantastic work that that Fred Hollows has been doing within that project. A few highlights for me were that the project just has this amazing involvement of the local government, inputting into their plans, and with the local government contribution as well. HR came out very strongly, quality of cataract surgeries, and also the importance of the right mix of the team. And great engagement with the health insurance scheme, as well as other cost recovering mechanisms, for example, speciality services. So we've actually got our second presenter here now. So I think what we'll do is we'll listen to both presentations, and then we'll do the question and answer session. So I can see that we've got quite a few questions coming through already, which is wonderful. So if you do have questions for Anne from his presentation, please start writing them in the chat box on your right hand panel. And then also during Arundhati's presentation, now if you have questions for her, please, once you have the question, you can also send them across to me so that we can make sure your questions get answered at the end. So thank you very much, Anne, for a really interesting presentation. I'm now going to introduce you to Arundhati Bhattacharya, who's the Program Officer for Sight Savers India, and she's going to take you through her presentation. So Arundhati, I think probably as with Anne, I'll click through the slides because it'll probably work out a bit easier doing it that way. So Arundhati, over to you.
Thank you, Suzanne. My name is Arundhati Bhattacharya. I'm working as a program officer for Sight Savers India, and I'm looking after the project funded by Standard Chartered Bank Seeing is Believing initiative, which is Sundarban's Eye Health Service Strengthening Project. So now I would like to start my presentation that sustainability is very important and highly relevant, especially in the healthcare setting. It is important to look at the sustainability as one of the key strategies while designing and managing an eye care program. Often people and agencies look at sustainability as financial viability, but Sightsavers as an established eye care organization looks at sustainability more comprehensively for sustained growth and development. So now I would take you to Sundarbans about the geography and the location. So this project is a part of the Phase 5 Seeing is Believing, which was designed considering the unique needs of the Sundarbans area. The Sundarbans is an unique biosphere reserve of mangrove forest and one of the global heritage sites declared by UNESCO. It is situated in the Ganges Delta, bordering the Bay of Bengal with a large component being in Bangladesh. It spreads over 2 districts and 106 small remote islands. Of this, 54 are inhabited, and it is an area of extreme poverty. 40% of the total population, which is almost 4.7 million, live below the poverty line, and 13% are officially declared as poorest of the poor. The 5 years project is supported by Standard Chartered Bank under the Seeing is Believing, which started in September 2013 with a goal to reduce the prevalence of avoidable blindness. The project aims to improve the coverage and access in the area, increase awareness and attitude, and increase the capacity of the government as well as the non-government organization. Next slide, please. This is the project operational model which represents the existing health delivery system at the left-hand side, existing system in the Sundarbans, and how it is contributing to the project operational framework. So you can see that the overall situation of healthcare facility in Sundarban is very poor, and vision problems are largely unaddressed due to low perceived severity. So there are like shortages of human resources like government frontline health workers, and absolute dominance of rural medical practitioners exists. And they are the only first source of service providers who are present in the community. So the vision centers are at the core of the project implementation, and where the patient inflow comes from community outreach program and school screening. And these vision centers provide accessible and affordable high quality eye health services and conducts activities like refraction diagnosis of cataract, prescription and dispensing spectacles, referring patients to partner hospital or government subdivisional hospitals. So there is a strong linkage between the vision center and the hospitals run by partners and government. And these VCs also act as a referral unit whereby patients requiring surgeries are referred to this hospital. So these are the project deliverables which we aim to achieve in 5 years. I am not going into detail. You can see the numbers which are mentioned. We are aiming that we will, at the beyond, after the project is over, we will have a 17 sustainable vision centers, and also like 3,120 adult and 200 pediatric cataract surgeries. So this is the sustainability. Next slide, please. The next slide, please. Yeah, this is the sustainability framework in the project, which I will talk about, and to today's theme also. So you can see like there are 4 pillars, because I already mentioned that this is not about financial sustainability, but Sightsavers also emphasizes on the demand sustainability and the sustainability of services. So under this initiative, major health workforce or human resources, both from the government and non-government, are being trained, who will contribute to the community beyond the project cycle. And also the referral network being strengthened with setting up and providing infrastructural support to 3 partner hospitals in Sundarbans. And also the capacity of government hospital is being increased with strengthening their infrastructure and technical capacity to provide quality eye care. And also we have component of financial sustainability, which I will talk about later on. Next slide, please. The next slide, please. This is the Vision Center model where you can see like from Vision Center what kind of services we are offering. We are offering door-to-door awareness program, community outreach program. We are also organizing training and skill development program, and we have outreach camps and school screening camps from where patients and children they are being referred to the Vision Center. And at the Vision Center we are also conducting screening, prescribing and dispensing spectacles. And if there are any cataract patients, then we are referring them to the partner hospital, which are also supported by site savers. And if needed, then we are also referring them to the tertiary care hospital. Now, this is I will explain the cost, Vision Center cost and the revenue tree. Like the Vision Centers are operating on a sustainability model. The project design has an embedded element which helps in making these centers self-reliant and thus continues providing services and working towards better eye health in the area beyond the life of the project. So the core of the Vision Center is the concept of sustainability, which aims towards generating enough revenue to be able to support the expenses like running cost of the VC and HR cost. You can see there are specific heads like manpower, consumables, general and administrative cost head, then corporate expenses and also capital expenditure. So these are the Vision Center cost head. And in the next slide, you can see the Vision Center revenue heads. So each of the Vision Center is operating on a business plan to make it sustainable on its own. And the business plan outlines the minimum number of screening and spectacles the centers are supposed to conduct and sell per day to be able to bear the monthly expenses. So you can see like the Vision Center revenue head, and there is also a new revenue head which we have created last year, that is the 10% profit sharing by the base or partner hospital for every paid surgery which is referred by the Vision Center has also been added, and it is like boosting the revenue to a very good extent. Next slide. The next slide, please. So this is the journey of a Vision Center towards sustainability. You can see like there are 5 phases, and there are activities which we have done in each phases. It was not a very easy task. So like in the very beginning, you can see like setting up of the VCs in strategic locations, then diversification of products, then affordable user fee at the VC. These were like the main parameters. Then we also offered a bundle of services at a subsidized rate and organized door-to-door and community level campaigns so that people are aware of the VC location and the services which are being offered from the VC. And at the nurture stage, which are the initiative has been taken to nurture the VCs, like capacity building of the staff, developing the business plans. Then we are also training the staffs on sales counseling so that they can, offer appropriate and customized services to the patients. And strengthening of the Vision Center, like strengthening in terms of physical infrastructure and also technical capacity. And we have also developed different information, education and communication materials, and brand building of the VC has been done. So this is the nurture stage, and in the next stage you can see like we have strengthened the referral mechanism through training of different stakeholders who are from the government and from the other frontline workers and from the community. So we achieved like the spectacle conversion rate. We have observed that it has increased. The new revenue head for each surgery referred, which has been added, which also like converted the VC towards sustainability, and we have also introduced selling of sunglasses from the VC. And we have engaged local government bodies, health ambassador, youth clubs who are the local people, and we aim like that we will achieve where the VC footfall will increase and the VC, like all the VCs will be sustainable where they can earn their own revenue. So these are some of the performance of the VC. We have at present 17 Vision Centers, and you can see this is the January to March data which I am representing in terms of screening, refraction and the cataract referrals which is a new revenue head. So number of cataract which is being referred from the particular VC, for each cataract referral, 10% of the paid surgery will be added to the VC income. Next. The next slide, please. So this is the spectacle prescribed and sold from each and every vision center. We do also have a provision for free spectacles which we distribute from the school screening camp and outreach camp. But as part of the business model, we are selling spectacles in a subsidized rate from the vision center. So you can see like almost maximum number of VC, 9 VCs, they have spectacle conversion rate above 80%, and some of the VCs which are still growing and will be strengthened further, so that all the vision centers we look forward to have spectacle conversion rate above 80%. Next slide, please. The next slide, please. This is the vision center income and expenditure analysis for the last 3 months. You can see the like one VC, the first VC is above 200%. They are able to recover their cost like 200%, and the 9 VCs are above 100%, and following 2 VCs 95%, 2 VCs above 80%. So there are VCs like which are at 60 and 50%. So we are working on those VCs so that they can also improve and like revenue, earn their own revenue, so that they can be also sustainable. Next slide, please. So overall, I'm happy to share that yes, we are reaching towards sustainability. At present, out of 17 vision centers, 10 vision centers are able to recover their own expenses, and the percentage of cost recovery is above 100% for these 10 VCs. The infrastructure development which has been undertaken will provide the lasting resources to enable services to continue beyond the life of the project. And another lasting change will be the training provided under the project for government and non-government workers. And the multidimensional awareness raising events has reached to a large proportion of the population of the Sundarbans, with the aim of increasing knowledge of eye health and how and where to access services and increase health-seeking behavior. Thank you, everyone.
Thank you, Arundhati. That was a really interesting presentation, and I think what really comes out really strongly for me is the issues around comprehensive approach to sustainability. You know, the financial analysis is really sound, and the fact that you're looking at which vision centres are doing well and what lessons can be learned from them. It's really interesting. And then even sort of your vision centre model, that you're doing continuous outreach even post-project, so you're still going to be going out and looking for patients and bringing them in. So that's really great, and continue to kind of invest in that, knowing that it will lead to more patients. So thank you so much. That was a very interesting presentation. So we've had 2 very interesting presentations. So we've already got so we're now going to do the question and answer session. So if you have any questions for either Anne or Arundhati, if you could please write them in the chat box now. We already have about 6 or 7 questions, so if you do have a burning question that you want to ask, please do feel confident to ask it, because there's sort of quite a participatory element to this part of the webinar now. So please do feel free to ask questions in the chat box. In the meantime, we're going to start with the questions that we have. So first of all, we've got a question from Harish Kumar. We've got a couple which actually are for Anne. So Anne, Harish is saying that you spoke about allocating 30% of income for your personal development training. Do you charge from patients for surgery, or how do you manage that? And then a second one is around how do you increase the volume of surgery? And did you conduct the screening camps, and can you share the strategies? And actually, I think that second one is probably relevant for both presenters, because also for Arundhati, with the numbers who are coming into the Vision Centre, what were your kind of key strategies that you were increasing those numbers? So, Anne, do you want to start by taking those first two questions, and then Arundhati will come on to you for the second one about increasing numbers?
Yeah, thank you for the questions. First, I would like to answer the first questions. It's meant about allocate 30% of interest for the internal developments and provide services. That is, under the projects, we supported our hospital partner to set up some eye services like spectacle shops and cataract surgery services. And then from these services, they can collect some income back from the patients and also from the health insurance. And for your information, in Vietnam, around 55% of the population have health insurance cards, and health insurance companies pay for the cost for the cataract surgery. It means that when the hospital provide the cataract surgery to the patients, it depends on the categories. The patient will make their contribution depend on the category they belong to. For example, poor people, they get the free health insurance card from the government, so they do not pay anything. The second category, that is the near poor family, will pay 5% of contribution, and 90% will cover by the health insurance. And for the people who do not have a health insurance card, they have to pay 100% to the hospital. And from the incomes they collect from the patient, from the health insurance, the hospital in Phú Yên or in other provinces, they also allocate partly of their interest to do some staff developments, because they already think that if their service is good, then more people will come and they can provide more treatment to the people, and the more income the hospital will get. For the seconds about the increase the numbers of the cataract surgery or the people who seek the eye care service, we support them to strengthen the network. I mean the health network from the hamlet level. And these hamlet health volunteers were trained on primary eye care, and they know what groups of the people often have a cataract, and then they identify the people with the cataract and make a list of the potential old people who may have a cataract and refer to higher level for screening. And these people, because of thanks to these hamlet health volunteers, more people know the cataract are treatable, so more people can access to the cataract surgery, and the number of cataract surgery is increased in the last 10 years in Vietnam.
That's great. Thank you so much. That's really interesting. Okay, Arundhati, what were some of the key strategies you had in terms of increasing footfall into the vision centres?
Well, it was not a very easy task to increase the footfalls in the vision centers, because the communication facilities are very poor in Sundarban area, and also like conventional communication systems like telephone, and also like very few people have access to newspapers and all. So what we have done, we have organized different and several outreach camps within the 10-kilometer radius of the vision centers, and the vision centers were also set up in a very strategic location, which is like easily commutable by local people. And this was like door-to-door and community-level campaigns were conducted. And we have also worked a lot on the developing information, education, and communication materials. And we have also branded our vision center with a particular name, like which we call in Bengali Alor Disha, which means towards light. And the name of the vision centers and the brands have been like displayed in the Sundarbans area. And like since the Sundarban area is like 70% is water, so like route direction and hoarding have been like put up in so that people know where are these vision centers. So those were done. And also like we have engaged local clubs and local stakeholders so that they also like mouth of words, by mouth of words, like this kind of information also reaches to people.
Thank you. They seem some really interesting strategies in terms of dealing with that specific location and the challenges there. Thank you both for answering those questions. Now, we have a lot of questions coming, so I'm going to try and group them together on themes. So there have been quite a few questions on human resources for both panelists. There's one around quality. So how do you, for both of you, how do you ensure sort of the quality of your training, particularly around at the primary eye care level? And that's from Farah Riaz and from John Trevelyan. And also, so they're sort of the first ones, how do you sort of ensure quality, particularly for the primary level? And then secondly, how do you resolve the issue around staff retention and staff transfers? And that's from Andrea Adler and also from I lost you, from my colleague Yuda. So they're basically, they're sort of the questions. How do you sort of ensure quality in training, particularly at the primary healthcare level, and how do you resolve the issue around staff transfers and retention? So again, shall we start with Anne and then go on to Arundhati to give you both sort of a chance to think about it?
Yes.
Please go ahead.
I start first. For the qualities of the trainings, we have a different trainings at different level. For primary level, means the hamlet and commune level, we just provided the training for the health staff on primary eye care. And we work with the good training center to develop a manual for trainings. Basic informations and what it meet with the qualifications and capacity of the commune and hamlet level. And we also provide the train of trainers, and these train of trainers, TOT trainers, will provide the training to the primary eye care to the lower level. And we also require the trainer to conduct the pre-test and post-test to ensure that the trainees catch up the knowledge they learned during the primary eye care training. For the higher level, like a basic eye doctor, optometrist, refractionist, or surgeons, we have a strategies that we discuss with the leaders of the hospitals, and to select the commit staff with some standard that they have to come back to the hospital to work there and serve there at least 3 years after the trainings. So that is the first retention of the staff. And the second, that is we require the training centers to provide both theory and practice training to these staff. And we also have some follow-up training for these staff after the first training. And some staff, they also require some hand-on trainings. For example, we send some staff from Đắk Nông and Lâm Đồng to Bình Định province, where we have a good practitioner, and they learn a lot from the hand-on trainings, so they can do the job when they come back to their own hospitals. That is the strategies we do in Vietnam to ensure the qualities and to ensure that the staff who receive the training come back to the hospital and do their job.
Brilliant, thank you so much. Arundhati, how about for you?
Yeah, basically we do also have different trainings for different levels. For the frontline workers who are the community health workers, we have our own technical training lead, which is one of our partners. So they conduct, I mean, they develop the training module. They also do it based on the need assessment from the staffs. So they conduct the training on the day of, I mean, after the joining of the staffs. And after that, we also have refresher training for this kind of staffs. And for the managers, program managers level, for who are the project coordinators and the optometrist opticians, we have tie-ups with pioneer eye institutes and eye hospitals, where we send our project staffs for training, to take training on these institutes, and which are, I mean, which also provide hands-on training to the staffs. And we also do like conduct advanced level of training after they continue for 1 and 2 years in the job. We also do offer them the advanced level of training. So this way we do, and all these trainings are also supported by hands-on experience, where they learn the theory and also they practice it in their place where they are working. And in terms of staff retention, we have recently introduced like reward and recognition for the staffs, because which motivates them a lot. So we have recently like decided on some criteria, and which we have shared with our partners, and our partners have nominated like staffs from their respective organization, and they were being rewarded with a certificate and mementos, which motivates them a lot. And along with that, definitely there are like every year, along with their performance appraisal is being done, and accordingly, I mean, benefits and allowances are being provided to them, so that staffs get retained.
Great, thank you for that. That's really interesting to hear about those different strategies that you're doing within the projects. We've just got a few minutes to go, so if you do have a burning question for either of the presenters, now is the time to send it in. This is probably sort of the last chance to sort of send any questions in. But I'm going to carry on with the questions we've got, because we do have quite a lot. So one is sort of about funding, and there's slightly different questions for each of our presenters, but I'm going to read some of them both together. So to Anne, it's a question from Courtney Saville, which is, how long was the Fred Hollows Foundation working in Vietnam before it was able to secure co-contributions from the government for eye health programs? And do you think that this is something that takes time, or something that should be pursued from the sort of onset of your program? So that's around sort of government contributions and how you work with governments in that sort of advocacy role, I suppose, and how long that takes. And then for Arundhati, we've got a lot of questions coming in for the vision centres. For example, from Andrea Adler, who's asking about profitability of the vision centres, and they would be interested to know which of the vision centres are faring better than others, and what are the success factors for those vision centres that are doing well. So would you be able to take those? So, and if you take the one about government co-contributions first, and then we'll come to Arundhati about the vision centres.
Yes, I think that at the beginning of the projects, we already communicate with our partner that we are NGO, and our contributions to initiate one pilot model or at the first, and after that the government and the government hospital will take over this work to take care of the people. So we negotiate with our partner at the very beginnings, and at the moment we also apply that the government is required to contribute at least 10% of the total budget of the projects. They can contribute in different times. For example, contributes the labor, contributes the staff time, working times, and contributes to the constructions of health facilities. And they, for example, we conduct a training, and our partner can provide free the conference room, or they in construction they can contribute up to 40% of the cost of the buildings. And we apply this model successfully in Vietnam, and some eye hospital at provincial level we just provide only 50% of the cost, and the remaining 50% were contributed by different sectors like the Ministry of Health or Provincial Department of Health and the people committees. And I think that in Vietnam, the government very supportive with our program, and they realized that to prevent blindness for the people, they can benefit in social and political sectors. And as you know that each blind people in Vietnam receive a certain allowance every month, and if we support the people avoid from blindness, it means that the government will not have to pay allowance to the blind people.
Okay, thank you. That's really interesting. Right, Arundhati, over to you.
Yeah. As I mentioned in my presentation that the project design has an embedded element which helps in making this center self-reliant, and it will continue providing the services and working towards like in a better eye health in the area beyond the life of the project. So like in the first year of the project, a detailed business plan was developed based on the user fee and sales of spectacles, and this business plan also varies from vision center to vision center. So if we see like the vision center, if the vision center has maximum number of footfall or increased footfall, then like the screening will be more. If the screening will be more, the number of refraction will be higher, and the chances of prescribing and selling spectacles will be more. So this is the main thing. So increasing the footfall, I mean the vision center which have really done well. If we analyze, then we will see the screening are higher in those vision center, and accordingly the refraction and spectacle selling. And along with that, I have also mentioned like the vision centers. They have referred many cataract surgeries to the partner hospital, and where for each surgery 10% revenues have been added to the vision center. So these are the main key factors, and definitely to increase the footfall, we have done a lot of community mobilization activities. That is another thing, and these are the main success factors for the vision centers. Thank you.
Great, thanks a lot. And then this is a question for both of you around, excuse me, around referrals, which is from April Zhu, which is what actions are made to make sure patients come into the Vision Centre from referral and then are referred upwards? And I think that's also relevant for the Fred Hollows Foundation project as well. How do you ensure that patients that you find at the community level are being referred up and are taking those referrals? And also, so a second sort of question related from Dr. Mahan Krishna Shretha, which is also around, do you use any databases or HMISs, or do you use any sort of data management to track patients and ensure that they come back down? And so again, should we, yeah. go ahead, Anne, and then we'll come to Arundhati.
Yeah. In case of fret hollow formations, our partner has not applied the SiMS system. So in our program, we propose our partner to use manual books to when they do the screening at one commons, they identify, let's say, 70s of patients should be referred to the higher level for cataract surgery by the eye doctors. And then they also have some commitment for at the higher level. They send a bus to the communities and takes the cataract patient to the hospital for treatment on one day, and then they return them to their communities in other days after 2 days treatments at the eye hospital. So by doing that, the people are willing to go. I mean, the cataract patient are willing to go, and then the list of the patient who already received the cataract surgery also send it back to the lower level so that they can keep track and they can monitor on the visual visions of the patients after the cataract surgery. Over to you. Yeah.
Great, thank you. And then Arundhati, for you, how do you ensure that those referrals are taken up?
Yes, we do have a MIS in the project where, like, each and every vision center, they record the data of the patient from where they are coming, and they are being referred to the partner hospital. At the same time, at the partner hospital also, we have a system where the patients referred from the vision center, whether they are reported or not, it is being tracked, and if they are not reporting, then that information is also comes to the particular vision center where the community health worker, they can track it. And apart from that, we also have a very unique geographical information system, or GIS system, for tracking the overall, I mean, from where the prevalence is and from where the patients are coming. So, like, for this, we have block-wise GIS maps, which has been developed as per the population prevalence and blindness and service uptake. And these GIS maps are being updated based on the patient data, which I talk about, received from the vision center. And these GIS maps also help the community health worker to plan community level mobilization activity in an effective manner. So we can also monitor from where patients are coming, where, like, the prevalence are higher, where we have already reached or not. I mean, the unreached areas can also be located. At the same time, we can also plan mobilization activity, and and we also have a performance vision center performance thing, where, like, every month our partners send the detail of the income and expenditure for each and every vision center, which we analyze, and we can see where, like, which vision centers are lagging behind and what are the reasons for that and how to overcome those. So these are being done on a regular basis.
Great, thank you. Thanks for that. Right, I think we're gonna have to, we've got one final question which I think we're gonna go for, and then I think we're probably gonna have to round it down because I'm aware that I'm taking quite a lot of your time, but the questions are so interesting I don't really want to stop, but we must at some point. So finally, we've got a question from Farah Riaz, which is around your sort of, how do you set your annual targets for your Seeing is Believing programs? And I think that, again, that's relevant for both, but it's also around how do you work with the Department of Health to do the target setting in terms of the numbers that you're estimating that are going to be screened and then treated. So how is that? How do you go about doing the target setting for that? So again, we start with Anne and then go into Arundhati.
Yeah, I would like to reply to that questions about the setting the targets for at the partner size. In fact, setting target is a very difficult task. We have to consider the the achievement of last year, the capacity of the partners, and also the effectiveness of the communication activities, and the fund available. And all of these factors will help you to have a appropriate target setting for the year. And for example, in one province, the provincial Department of Health will discuss with the district lower level general hospital to set, ask them to set target, and this target will be divided into to this each district, and then consolidates, and that is the target of one province. So as I had just mentioned, to set target for annual target for blindness preventions, it should be based on several sectors. The capacity in terms of service providers capacities, the fund available, the effectiveness of the communications activities, and also the last year performance. These factors will inform you how to set an appropriate target. And usually we do not set a high target out of the capacity of the partner, because if we set large target, then the partner cannot achieve.
Great,
That's
thank
it.
you.
Thank you. Yep.
Thank you. And then Arundhati, over to you.
Yes, basically the target is being set definitely on the prevalence of the problem. And if we see, like in Sundarban, particularly this phase 5 Seeing is Believing project is aimed to reduce the avoidable blindness, and in Sundarbans, like 83.8% blindness is due to cataract. So definitely the surgery, the cataract surgery target which we set in the project initially, that has been increased 33% in between the project, because we have seen, like from our project area we are getting many cataract patients. So initially the target was 27,000, later on in between we have increased it by 33%, and now the present target is 33,120. So that is also I think one of the main thing for setting targets, which we have revised, which was in the initial project, which has been revised later on also. So that is the main thing, and definitely it depends on the area where the partners are working, how many vision centers they are running, and their total geographical area covered by them, the number of staff they have, and also the capacity, individual capacity of the partner. But definitely this is being discussed with the partners time to time during the review and also in the annual meeting, so that we can reach the target and we have proper planning to reach the target. Thank you.
Great, thank you. Yes, and it's that sort of balance, really, isn't it, between working out what the prevalence is and also really thinking about how then you're going to be able to manage that prevalence and also the capacity on the ground, and also thinking about it in terms of sustainability, how that's going to continue once the project's finished as well. So thank you both. Right. I would love to carry on talking as and listening as I mentioned, but obviously we do sort of need to draw this to a close. So if you do have questions that you wanted to ask or you feel weren't answered, if you could email me those questions after this webinar, and then I can forward them to our two speakers. But I would like to end by thanking our two presenters, Anne and Arundhati, for their comprehensive presentations and responses to all of the questions that we had. Thank you to Saloni for all the technical support she gave me. I really appreciated that. And thank you to all of you who've participated. And I really appreciate you not only taking the time to be part of this Seeing is Believing learning community, but also time to engage with it, with the presentations as well. And we had so many questions, and I really appreciate that. So thank you so much for sort of being part of this. if you would like to share your own sustainability strategies with the wider Seeing is Believing community, sustainability is one of the themes for the next Seeing is Believing newsletter, so you're welcome to submit articles to me by the end of June. And now I just have one final favour to ask. I'm now going to email you all the Seeing is Believing webinar survey in sort of the next 5 or 10 minutes. So if you could please just take 5 minutes to complete it, as your support for these webinars does make them possible, and your feedback helps us to improve them and make them more useful for you. So thanks again to everyone, and I look forward to seeing you at future Seeing is Believing webinars. Thanks all.
Thank you. Thanks,
Thank you.
Suzanne.
Bye-bye.
Thanks a lot. Bye.
Goodbye.
Bye, Susan. Thank you.
Bye.
Bye.
Bye-bye.